I'm pleased to welcome our guest speaker this month, Dr. Evan Lewis. So I've had the privilege of knowing Evan, I think, since C4T started many years ago, back in 2018. And so looking forward to hearing from lots of your experience today. For those of you who haven't met Evan before, Evan is a board certified adult and pediatric neurologist and a clinical neurophysiologist and epileptologist. He's an adjunct assistant professor at the Hospital for Sick Children at the University of Toronto. And his clinical practice focuses on epilepsy, concussion, and persisting symptoms after concussion, brain injury, and functional neurological disorder, particularly functional seizures. And he's treated patients with medical cannabis for over a decade and published several articles in this space. And today we've invited him to talk about medical cannabis oils, dosing, and guidance for safe and effective treatment in adults and children. So with that, I will invite you, Evan, to take over the screen here.
Perfect. Thanks, Lauren. And I know it has been some time that we've known each other. It's to think about it, it's pretty wild. Hi, everybody, and pleasure to be here and talking to the group. And always love all the work that's being done here. And it was part of C4T. So the focus today, as Lauren has nicely segued, is on medical cannabis oils. Dosing specifically just for oil. So ultimately, this has been a work many years in progress that culminated in the publication of a textbook and some guidance, which that's what I'm going to walk through today and kind of show you the utility of this and where we can go with dosing as we venture forward with cannabis research and using cannabis clinically. So this is me. Lauren has mentioned a little bit about my background, but yes, I've been working in cannabis for quite a long time now, and have treated thousands of adults and kids, and a lot of that focus has been in epilepsy. And what you're going to see today, and the work that's come out of this book is a combination of that experience plus the evidence that exists. So this is the outline, kind of just really to talk very quickly about why it's important to standardize dosing and have dosing, and then look at kind of the first step in moving forward with dosing in a practical, systematic way. And then I'm going to walk through a case in doing that, and then hopefully have some time for some questions. So looking at cannabis overall, where does it come from in terms of epilepsy? It's a bit epilepsy focused, but just generally overall, right? You've got CBD THC isolated by Raphael Mechoulam in Israel at the time in the early 60s. And a lot of people don't know this, but the first kind of work that was done was actually quite early in epilepsy in around the 70s, where in the rodent studies started to see some impact on CBD. And there was actually a clinical trial where 7 out of 8 patients responded. And this was in the 1970s. Moving a little bit forward, we start to then discover elements of the endocannabinoid system and its components like the receptors and the ligands. And this is where we start to realize that there's actually some mechanistic insights here that we can gain from and start to focus a little bit more of our work. And that was done ultimately in the early 2000s. CBD is shown to modulate neuronal excitability. This, fast forward to Charlotte Figi and the CNN documentary that was aired by Sanjay Gupta, and that really it spurred and the idea of utilizing cannabis to treat conditions very seriously in the public eye around that time. And if you were involved in cannabis in that space, or remember, it was quite fascinating how quickly everything really shifted. And that was in the launch of the Epidiolex trials for CBD and Dravet syndrome and Lennox-Gastaut syndrome, really complex epilepsy syndromes. Ultimately, the approvals. Okay, so this is a very quick oversight of the history. Well, where does it bring us today? I mean, through all this, as Lauren has pointed out, no one has ever standardized dosing. Like if you look back at all of the work that's been done, tens of thousands, probably millions at this point throughout the world of people who have been treated, directly and implicitly with cannabis, there is zero standardization of dosing anywhere. Really, when you kind of dig into where the dosing came from, it will surprise you. I implore you to do that on your own one day if you have the interest. So there really isn't much. And when you look at some studies in the literature that talks about this, like here's just an example. Here's a systematic review that was published 55 studies, 21 different diseases. Look at the range of THC here. Now, that that that's huge, right? We're talking the order of magnitude of tenfold plus here, right? Of a weight-based dosing of THC. Now, THC is very sensitive, right? So that's, the CBD range is going to be much bigger, which it is, right? Like 50 times the dose of CBD that's been studied in literature. What do you do if you're a newcomer to cannabis and you really want to do this with your patients? Where do you look? Who do you talk to? If you're not part of a group like this, you don't have a mentor in this. You're digging through the research to find your own dosing protocols, or nowadays, maybe you might be turning to AI, which is probably not a good solution in this case. Um, you're really stuck. And so it's a barrier of entry to clinicians and therefore a barrier to patients, and also opens up massive gaps for harm in this space. Or lost opportunity on the other end, maybe just not dosing properly. And so you've got a child with epilepsy that could respond to cannabis, but you just don't know how to do it. And so that was really the impetus. And I started to see this with some of my colleagues very early on, knowing that I really think this is like the next horizon for cannabis where we have to go for those who really want to be responsible in the space. And when this was just a recent article, I mean, not so recent, but recent in terms of this year, March 16th, 2026. Here's what happens in terms of, like, as I said, lost opportunity, right? This was a systematic review, meta-analysis. It made a lot of headlines when it came out and was published earlier this year um, in the mental health space, and essentially said, given the scarcity of evidence, the routine use of cannabinoids for the treatment of mental disorders and SUDS is currently rarely justified, and then made a ton of those headlines here, especially in the UK, some in Canada. The problem was, it's like they're basically saying cannabinoids are not useful. But when you look in this study, you look at the variety of dosing, it's like, of course, that's the outcome. The dosing is so inconsistent. And so, that gets ignored in a study like this. So I'm not here to say this was right or wrong in the interpretation, but the interpretation is based on the backbone of variable dosing. And so you have to take from it. There again, it could be that this is true. It could be that it's totally untrue. So this is the problem that we get clinically. Okay, so that kind of I will introduce and move to kind of the book that we've developed and put forward. This is it here. What is it? It's a book that has kind of parsed into two sections. We do kind of go through some background around the endocannabinoid system in the first part, talk about pharmacokinetics. So there's a primer at the beginning to really set people up to understand cannabinoids and kind of how they're utilized. And then we kind of talk about how to dose, like what kind of framework should you take into dosing. But above all, it's a standardized dosing framework. And this is kind of the process by which we developed the textbook. So again, speaking to the history, I started to recognize this as a clinical need in 2020 with some of my colleagues. We started to think about and conceive how do you standardize this in terms of a table structure. That happened there, and then we spent a couple of years digging through the research, and then synthesizing the research. Developed a first draft. He then expanded to include some more conditions outside of epilepsy and autism and some others, and finally published in 2025. Um, One of my colleagues has a plan to kind of do this for inhaled cannabinoids. I think that's a much, much more difficult venture. So we'll see how he does with that. What kind of research did we do for this? Really, it was through our colleagues. We took, people who were in the space, have been there for a long time, a lot of speaking with them. A personal audit that we made at our clinic, where again, we've treated kind of over thousands of people. We published one study where we looked at seizure freedom. There's another one coming down the pipeline. We looked specifically at about 160 of our patients, but we did a chart review overall of about 500 plus, and so pulled some of that data from there on epilepsy and other conditions. Ultimately, went through the literature, and we have about 194 citations in this textbook, plus other kind of references and abstracts, again, leading to the publication in 2025. So again, this is the book here, and here are the conditions that we ultimately landed on. So it contains dosing for these conditions that you'll see here. And then there's kind of two things here we looked at. We looked at kind of how do you reduce people who are inhaling too much cannabis. So in the context of perhaps CUD, is cannabis use disorder, And also just generally, what are some safe ranges of general movement upwards titrating? And how do you wean people off in situations that you need to do that as well? So we tried to standardize that to some degree. Okay, so let me show you kind of what it looks like in this case. Um, I'll start with kind of that general titration and weaning, right? So the idea here is that when you're working with cannabis, you've got this range where it's kind of optimal. You can dose within here, but obviously too high, you get side effects, too low, you might be ineffective. So what is that range and how can we work with that? And that's the idea here I was just mentioning before. So here's an example of how the tables appear. Okay. They all kind of look similar. These are the only ones that look a little bit different. So we considered things like, okay, you have CBD. Oh, and just to mention, we only focus on CBD and THC. So this does not include minor cannabinoids or anything else, and does not and looks at CBD and THC independently, right? Not in ratios. You can make the ratios if you want, but again, if you look back and find out where all the ratios came from, you'll be surprised where the 1 to 20 comes from, or 2 to 100. Like, what are these ratios? Who decided upon these? And if you go back and look at the history, it's completely arbitrary. So we separate them both out. I've always practiced cannabis like this. I've never utilized oils that have set ratios. So as an example here, here's a CBD. This is a slow titration. So what you do is you want to use one without kind of THC in it, whether that's an isolate or a broader full spectrum with minimal THC. Um, we separate all weight between 30 and 30 kilos. That's the draw, okay? Because if you kind of look at, for instance, Epidiolex literature, they've got adults in their trial who are 60 kilos and they're dosing them at 20 milligrams per kilogram per day. If you're practicing cannabis medicine and you do that and you're giving 1,200 milligrams of CBD a day to a patient, like you're going to get side effects off doses like that, and it's not going to be useful, and it's not necessary. Plus, it's really expensive. So there's a reason for the 30 kilos. If anybody's curious, I can let you know. But this is the inflection point at which we move from weight-based dosing to standard dosing. So as an example here with the CBD slow titration, we have a starting dose. There's your starting dose there. We give a weekly titration rate. So here's a range that you can titrate from weekly, right? So if you're kind of a bit more conservative on the low end, this is the upper end. Here's a tolerable, oops, sorry, here's a tolerable dose on average daily. So this is kind of what you're going to get to tolerably. This is maximal tolerably. So what does that mean? That means from the literature, once you get to these doses, this is where you see side effects that tend to beyond that outweigh the benefit as an example. There you go. There's your side effects dose as well. So here's like an example of a slow titration for CBD THC. THC is modeled the same way. Okay. Let's say you're in a situation where you did fast titrate. So what's like the quickest you could do this? And so here again, a range in which is a safe way to quickly up titrate somebody if you need to. Likewise, on the other end of the spectrum, what if you need to wean somebody for various reasons, right? Going into surgery, switching medications, traveling, etc. Again, separated by weight. Here's an example of a slow wean. There's your frequency, a rapid wean if you need to, and then there's always some notes on the side here what happens. So again, this took like a year to develop the formats of these tables. So we tried to make it as kind of just user-friendly as possible because again, it's such a complex space when you really dig into the nuances of dosing. Okay, so same for THC as well. Um, okay. Okay. So that was just an example of the titration and weaning tables. As I said, there are tables for every single condition specifically. Okay. So again, that was just general. So where do you find that? Like to come back to this, like in what scenarios? I kind of explained some, like if you really had to just make decisions, fine, you could use them there. So this could be condition independent, but this is also, we don't have a section on palliative care. We don't have a section on kind of like complex, presentations with mixed disorders and things like that. So sometimes you meet people like that and they just want to treat for various different reasons I've encountered, right? But like in the palliative care space, you're kind of like, potentially trying to hit different things. In pediatric palliative care, especially, you might be treating for neuroirritability. Like, where does that fall in? And I have requests for that sometimes. So that's where these tables are just kind of condition independent. You might use these types of things, as well as other scenarios that I just explained. Okay, let's look at specifically an epilepsy case and how you might go about using this. All right. So Here's a case. If anybody's heard me talk before, you may have seen me present this case, so I'm kind of like now, utilizing the thinking that went behind this at the time, which we then evolved into this textbook. So I'll show you kind of how it matches pretty specifically. So this is a 2-year-old girl who presented to me a long time ago. This is Quinn, and she had seizures that we just couldn't get a hold of. They were quite frequent. We tried, very basic interventions, as you saw previously, valproic acid, kind of standard medications you would use in a child like this, and nothing worked because it helped a little bit, but not completely. Okay, so that's what I said here. Valproic acid had some partial control, but really nothing, and we were heading to a surgical workup plan for her. For anybody interested, no etiology, everything was normal, genetics were all normal, so we didn't have a cause, and this is typical. This is the most epilepsies are idiopathic. We don't have an answer for them. Okay, so her seizures persisted, and the worst part was when you have a child like this, for those who don't know, you start to regress if you have ongoing seizures. So she was a totally normally developed child, and here she was now with severe ataxia, unable to walk. She's also unable, she has ataxia in her hands too. She's poorly coordinated in her hands. Any speech she had, she started to lose, and it was because her EEG looked like that. For those that don't read EEGs, chaotic mess of lines is not good. That's what you're seeing here. So, this is her mom, and at the time we decided to move to cannabis. Again, this was about 2017, 18. It was pretty early days. I was quite nervous at that time to do this with a child like that. So, some key principles. Okay, so what are some key principles of cannabis dosing? This is where you have to start to think about a standardized dosing protocol. Well, I've mentioned some of them, but this was all I always kind of thought this way. I was like, again, the ratios don't make sense to me. You're introducing two drugs. How are you going to know what's doing what? Plus, there was some pushback, obviously. Some people were pro to THC. It still persists to this day. Some people very anti-THC. So there was a bit of that tension at that time. But regardless of that, it was just like, it doesn't make sense. Like, why would you introduce two medications at the same time? So I always consider CBD and THC as two separate drugs. And they mechanistically are. And if you look at them, and they have some additive effects, but they have some opposing effects as well. So, how do you think about these things? Well, you separate them. And you don't consider one being more important than the other, right? And so foundationally, you start with CBD and then you can add on THC. Why would you do that? Again, arbitrary. Maybe you want to start with THC. Maybe that will be epilepsy care in 10 years. I don't know, but it's because of a side effect profile and and availability, but really side effect profile. You can titrate up CBD. It has impact and effect on its own, so it might be easier to do that clinically with somebody. So that's kind of like a rationale that you could use there. So that's the idea. So you create a base of CBD and then you layer on THC. And after that, if that doesn't work, you continue to then move to the other cannabinoids. Again, that's not part of this in the book here, but if as an advanced cannabis practitioner, it's like you're doing one, then you're adding the other, and then you're adding the other. And you would do it in a stepwise systematic way so you can control how the variables on your end. And so for epilepsy, it has 5 phases, of which a couple of the phases are split. So the phase one of epilepsy dose is establish that CBD dosing. So what's the established dosing? Here are your dose establishments: 8 milligrams per kilogram per day and 240 milligrams per day. Again, based on all of the synthesis of the research. No THC. That would be phase one. So when you do that, you say, okay, so I've got this child and we want to, get to this dose. How on earth do I do that now that at least I have a parameter? So as an example, if you're going to initiate phase one, you look at this and you say, okay, so patient's 2 years old and has a weight of 13 kilos. What do I do? Well, if you have the textbook, you open the textbook and you start to look. What does the textbook say? Well, the textbook says, okay, here is the table. So this is what they look like. Okay, so phase one for epilepsy, again, split into 30 and 30. Okay, it has your CBD side and your THC side, and then some dosing notes. And then the subsequent page would show how do you titrate up on this. So the phase one tells you, okay, for CBD, your morning dose is remember the total is 8, as I showed you. So you're going to split that BID. So the morning is 4 mgs per kg, evening's 4 mgs, and it's 240 on the adult side. How do you do that? Well, 30 times 8. Okay, so that's where that and then that's standard for everybody above 30 kilos. So 120, 120. Okay. How do I do it? Well, there you go. Here's my starting dose. So I go to my titration table for that phase. Here's my starting dose. Here's the frequency of the increase, it's weekly. Here's the amount I'm going to increase every week, and I'm targeting my total here and here. So, and Tichi, nothing. Okay. So this is it's very clear. This is what you have to do, and this is how you step. So your work now will be to just do the calculations for this. If you want to do this, just like you would approach any other drug that you would be working with, but at least now you have the parameters. So as an example, we say, okay, so here's our CBD dose for this child. Remember, she weighs 13 kilos. Okay. So what we do is, well, we need 8 milligrams per kilogram. Okay, so we need two. So let's just calculate what do we need here. Okay, so she's 13 kilos. You're going to multiply that by 8 milligrams per kilogram, right? We cross off the kilograms here. Kilograms, they cancel. 13 times 8. That's going to give you 104 milligrams per day. Okay, so that's our total dose. So now we know our total dose for the whole day, right? Well, if we have the total dose for the whole day, right, we just divide that by 2, and that's going to give us our dose for morning and evening. So you got to kind of just do that on your own. But like I said, at least you've got the calculations now. Okay. Um, this is showing it here. This is just kind of finishing what we just said, right? You could just kind of do it on your own as well. So there's a 52 milligrams in the morning, and it's going to be 52 milligrams in the evening. Okay. So this is how you can then just use the book for things like this. Okay, so now you know at least the milligrams. So I've got, I need 52 milligrams here, 52 milligrams here. That's the total dose. Okay, but the oils all are concentrates. They come in, we need to have a volume. So if the daily dose is 104, what's the final prescribed dose? Okay, well, we have a 1 to 100 THC to CBD cannabis extract as an example. Here are some options here, right? Well, let's just calculate this out. So I know I have 104 milligrams for the whole day, right? We already know that. We have this oil that's 1 to 100. What does 1 to 100 mean when you're in the cannabis space? What it means is 100 milligrams of CBD. CBD is always the second one. THC is the other. When it says less than one, it's pretty negligible. You can ignore the THC in those situations. Okay. This is kind of a convention that if there's even a little bit, so like in a full spectrum, they got to put it on there just to say it, but it literally means the THC is negligible. Okay. So we got 100 milligrams CBD per mil. So what do we do for this? Well, our dose we've calculated already is 104 milligrams per day. Well, we just invert this. This is one way to do it, it's like, right? And then so we're basically 104 divided by 100, okay? Gives you 1.04 mils per day, okay? So again, tedious. Doing this stuff is not fun if you don't play with it. I'm kind of going through it really quickly just to give everybody the idea, right? But at least you have the parameters now to do it. I think that's the key. Um, and at the very end, I'll tell you obviously where this goes next once this stuff is established and it's out there. So therefore, you divide that in two, and it's 0.52 mils and 0.52 mils if you have an oil of that concentrate. Okay, so that's how you would do this. You would do this, so now you have the schedule. You can give that to the patient, and you can just calculate this for kind of every increase per week and give them a titration schedule. So essentially, this is what we did for this patient, kind of just to frame this as a case. Um, when she introduced CBD initially, she did great. Okay, her EEG normalized. That was very nice back then. And September 2019, I'm just going through this quickly just to get to the next point. Unfortunately, her seizures came back despite being on that CBD dose. So now, if that happens in your case, you're like, okay, well, that CBD dose is not working. Now we're going to move to phase two. What is phase two? Phase two is optimization of CBD. So we got to the minimum, we got to the kind of standard average amount of CBD where most people respond. Now we're going to try to optimize it. Maybe she just needs more CBD. How do you do that? Right? Well, that would be phase 2A. So phase 2A here, again, here's your table. Your doses go up now, 10 and 10, 300 and 300. Okay. But there's a phase 2B as an example. Oh, this is much higher, 25, 25, 750, 750. Okay, a clear difference here. Why did we do that? Right? What's the difference between these? Well, where does this come from? Comes from the Epidiolex trials. Okay, so in the Epidiolex trials, there's two trials in LGS, one in tuberous sclerosis and two in Dravet. And you can see down here, this is 20 milligrams per kilo, 10 per kilo, 20 per kilo, 50 per kilo, 25 per kilo. Okay, so you can see in the Dravet and Lennox-Gastaut, they stayed at 20 and 10 in that range, but the TS studies, they went up to 50 and 25. And this was safe and it looks effective. More effective than 25? No, but it was also effective. So we have a range. There's a range. So there might be some people who actually respond at that dose, and we've determined that, through an RCT that it's safe. So that's the idea here. So again, the phase 2A, it's high dose CBD. Phase 2B is like your max dose. And so again, I'm showing you this really quickly to just the idea that these tables are grounded in the evidence to the best of that we can do that. And therefore, without anything out there, this is at least a start. It's at least the beginning of a map, we can say, right? I won't go through this because it's kind of the same thing. You would just calculate out and blah 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 blah. So, right, just for to get to questions, I'll kind of quickly move through this. Sorry, you can close your eyes. I'll just go fast and okay, so the last point I'll say here is remember our strategy. So this child went up for CBD, she failed the CBD. What do we do next? Okay, now we optimized CBD, didn't work. We're going to move forward. Well, now we're going to layer on the THC. Okay, so now we're going to phase three. So phase three, again, looks to the literature. The literature is the CBD is not that high. It's actually lower when people respond and the THC starts. So same mentality, here's what happens. Here's your CBD dosing. Here's the introduction of your THC. Here's how you titrate CBD. But remember, CBD it was up high. You actually want to bring it down. So this is where you had to decrease CBD and add on THC in this step. Again, this is just framing the evidence, okay? But the ideas and the tables are the same, and you would just use the tables and you would calculate this out for the patient, okay? Um, Long story short, this patient did really well once we introduced THC. There's our add-on THC or EEG normalized. She went from this to this. And to this day has been doing fantastically. She was 14 months seizure free at that time. To frame the case a little bit more, actually, she did have a breakthrough. But again, with the breakthrough, what happened with the breakthrough is she was just underdosed. She grew up, she outgrew. We just added back the THC back to that amount, the 6 mil, the dose that she had here, 0.2 milligrams per kilogram per day. She did great. We published her case here, and she's doing again to this day. She's been seizure free since we tweaked her THC. Okay, I went through that part really really quickly because I just wanted to get to
Yes,
the questions if anybody has.
amazing. Thank you so much.